Good afternoon, everyone, and welcome to Getting Personal with Parkinson's. Today, we're going to be discussing deep brain stimulation. Oh no, I hope I'm able to say it. Maybe there's something happening in my brain. Deep brain stimulation and more. This is a live conversation with Dr. Ritesh Ramdhani, whose expertise is in this area. And I wanted to just welcome you all to our series, Getting Personal with Parkinson's. This is something that we do every Monday at noon. I'm Caroline Colas. I'm the Senior Director of Health and Wellness at the Marlene Meyerson JCC Manhattan. And I'm also the Program Coordinator for the Edmund J. Safra Parkinson's Wellness Program here at the JCC. This program is supported by New York's largest healthcare provider, Northwell Health. And Dr. Ramdhani is from Northwell Health as well. You can find all about our programs at this link, www.mmjccm.org/Parkinson's. If you're on Facebook and joining us on Facebook right now, would you do me a favor and push the button share? Share what we're doing here today so that others can join us. They may have some questions too. And we want this conversation today to put a face to Parkinson's. So I'm going to ask Dr. Ramdhani some personal questions about him and his interest in neurology, as well as find out a little bit more about deep brain stimulation. If you would like to ask a question or you have one for us, please put it in the comment section and we will ask it today as well. Dr. Ramdhani, should I call you Ritesh or which do you prefer?
Please do. Ritesh is fine.
Ritesh. So tell me a little bit about where you're from, how you got interested in neurology in the first place. I know you have a 1-year-old baby, so.
Yes. So yes. First of all, Caroline, thank you for having me. It's wonderful to be, part of this. I look forward to our conversation today. I grew up on Long Island in New York. I lived in Queens early on, and then my family moved to the South Shore of Long Island. That's where I did all my schooling, and I sort of didn't. I never left New York. I went to NYU and then Mount Sinai for my medical training, where I stayed on for residency and fellowship. I was never able to really leave the island of Manhattan in any way, and my interest in neurology started in medical school. I actually my goal was never to become a physician. My goal was to be involved with research and drug development. But along the way, I realized that patient care was something that resonated deeply with me, and I went on to pursue that in medical school, and sort of fell in love with neurology. More so because of movement disorders and deep brain stimulation, which I was exposed to during my medical training. And after I saw that, and I saw what people can be afflicted with, and with the kind of brain disorders and the brain disruption that can cause such profound physical disability, it was something that that fascinated me, and motivated me to go into neurology. Plus I think it's one of the few areas in neurology where you could actually make a difference. It's not just about diagnosing; you can actually treat, and we'll talk more about that today with deep brain stimulation. But you could really reverse a certain level of disability in the right candidate.
Wow, that's fascinating. So you were actually in your training, and then you were exposed to deep brain stimulation, and you were like, wait a second.
Yeah.
This is something I want to pursue. And you've also pursued, my understanding is, an interest in other technologies as well, and how technology can support brain function too.
Yeah, when I joined the faculty coming out of training at Mount Sinai, my focus was on deep brain stimulation, but a fledgling area of sensor technology was just emerging. And I was exposed to that and started to work with it, and how you could, utilize wearable sensors to more objectively understand motor symptomatology, and how you could potentially combine that with deep brain stimulation as well as with pharmacological treatments. So it's
So
been an
what,
area that's been
yeah.
growing quite a bit.
So what is deep brain stimulation? For those of us that are just joining, we have oftentimes our listeners are people that are newly diagnosed or people that have been diagnosed and living with Parkinson's for a long time. It runs the gamut. So just
Yeah.
to give us a context, what is deep brain stimulation?
It's really deep brain stimulation it's a procedure in which a functional neurosurgeon implants um, microelectro microelectrodes into specific regions of the brain. And that microelectrode is then connected to a battery-powered pulse generator. It looks like a pacemaker-like device that is implanted under the patient's clavicle. And everything is internal. Nothing is exposed. And the neurologist is able to use an external programmer to connect to the device and deliver electrical impulses into that implanted electrode to mitigate a number of motor symptomatology that afflicts Parkinson's patients, things from tremor to stiffness to slowness. Um, so that's essentially what it is. It's really it's important for people to for viewers to understand that it's really not just the surgery. It's not like joint replacement where after you leave the operating room and you go home that you flip the switch and that's it. There's a whole other part of it after the device is implanted about fine tuning it, adjusting, customizing the stimulation to try to gain the most optimal outcome for someone.
It sort of reminds me of, I'm sure it's not similar, but it sort of reminds me, I have a dear friend who doesn't hear very well. And so every time she gets a new device in her ears, there's a whole adjustment
Yep.
process. There's a way to fit it. There's a way to adjust it. She has to kind of sometimes go in several times.
Mm-hmm.
She has to learn how to do that kind of thing. Is it similar in a way?
Yeah, there are some parallels there. The adjustments are done in the office, and now some of the newer technologies is allowing us to make those adjustments from a patient's home remotely. And we base the adjustments off of how patients are responding, what their symptoms look like, and as well as combining it with simultaneous changes to their medication. So as you take medications down, as you lower medications, you try to compensate by adjusting the stimulation. And so it's a little bit of a trial and error approach. But over the years, there's been some overarching principles on how you effectively deliver stimulation, and how to reduce the number of visits that patients have to make to the office, as well as the programming time.
So let's back up a little bit and go, like, really, I'm such a visual person, and I'm sure some of our viewers are as well. Um, they identify a place in the brain that this goes. Is it the same for every single person, or is it different?
There's really two targets that are considered for Parkinson's patients, two targets in the brain. One is called the globus pallidus internus, also the acronym is GPI, and the other one is called the subthalamic nucleus. That acronym is STN. And those are really the two main targets that are implanted, and they're close to each other. The STN, or the subthalamic nucleus, is implanted very frequently across all centers. And the reason for that is that it allows for physicians to lower a patient's Parkinson's medication, and that's for many patients who undergo deep brain stimulation. That's something that they're seeking. But we have 20 plus years of evidence that now shows that there's really no difference between the two targets when it comes to the clinical outcomes. Both are very safe, both will benefit patients in a very similar manner.
And it's an electrode, and how big is it?
About the size of a human hair. And
Oh
that's,
my gosh,
yeah,
that's small.
yeah. And so the neurosurgeon will make a what you call a burr hole at the top of the skull, it's a small hole, and they would sort of thread that electrode through the brain using imaging. So a preoperative MRI is done, and then in the operating room, CAT scans uh, um, are also conducted um, to enable the neurosurgeon to ensure that the trajectory of the electrode is where they intended. So once they've implanted the electrode, there's some clinical testing that's done in the operating room. So they may give some test stimulation. The patient's awake during that time. There doesn't feel any pain because the brain doesn't have any pain sensors. So when you thread that electrode through the brain, the patient, no one's really feeling that pain. Um, and so there'll be some tests that are done to help ensure that the electrode one is in a good position within that very small nucleus, and two, that there's some benefits that realized in the operating room, and that again helps to confirm placement of the electrode. The entire procedure
So
takes
is
about
the patient,
Mhm.
yeah, go ahead. How long
No,
does it take?
the last thing I was going to say, the entire procedure takes about 3 to 4 hours
Oh, okay. And is the patient sitting up or laying down?
laying down. So the patient will be in
Okay.
the supine position, laying down. There's usually a head frame, and patients should think about that head frame if they've seen pictures of it as sort of a compass. That frame, it gives the surgeon the coordinates, helps them map the coordinates based on the imaging that's done before the surgery, to identify the nucleus and to identify the trajectory they're going to take to ensure that because if the electrode is slightly off, it could certainly affect the motor outcomes. Uh,
Explain more about that.
mhm. So, there are we the technology DBS technology has really expanded in the last, I would say, 5 to 7 years. So we have a great deal of new programming approaches and features that we can use to compensate for an electrode that may be a millimeter or so off from the sweet spot. There's always a sweet spot in the nucleus that we want as physicians to see that electrode in. If it's not in the sweet spot, that's okay, because with the new features, we're able to now steer the stimulation towards where we think that sweet spot is. And that's where the art of this comes into play. You really want to be working with your neurologist, your DBS team, to ensure that the stimulation is as optimized as possible, that you're stimulating in areas that you feel will give patients the best outcome. Now, in the case where even with all the innovative features, if we're still not able to get the optimal outcome, or if we're running into stimulation related side effects where the stimulation is spreading to other regions that we don't really want it to spread to, then it may require repositioning of the electrode. It's rare, but it does happen. And I think that that's why it's so important for patients to sort of understand this process, and then understand the kind of questions. The more information they know about this, the more informed they will be to have that discussion with possibly a future DBS team.
Now, why would somebody want to consider this as an option for treatment in the first place? Let's go with that.
Yeah, so it works. It was approved in 2002 for treating Parkinson's disease, and there was 3 indications that it was approved to treat. One was tremor that had become extremely resistant to medication and was becoming starting to interfere with the patient's ability to do routine activities. Two was uh, bothersome wearing off. So those are the episodes that patients experience where their symptoms return prior to taking their next levodopa medication. So if patients are requiring larger and larger doses of medications in order to alleviate those wearing off episodes, um, that's also an indication for deep brain stimulation. And the third indication is dyskinesias, bothersome dyskinesias. And dyskinesias are those involuntary movements associated with taking levodopa that can be very disruptive to walking, will affect balance and can really be disabling as well. So those are the three main indications to consider someone for deep brain stimulation. You don't have to have all three to have the surgery. One is enough to justify getting
Getting that. So would someone come to see you and then you would ascertain whether they qualify for this surgery or if they would be a good candidate?
Yeah. So when someone comes to see me, the first thing that's going through my mind is I want to know what how long have they had Parkinson's? What has their Parkinson's symptoms been like? What has the progression looked like as well? And what are they experiencing motor complications, wearing off, dyskinesias, walking
Mhm.
problems, speech problems? I sort of want to get a complete overview of their Parkinson's state and what treatments they've been on. Um, and so if I feel that there's more treatments, medication, pharmacological treatments that haven't been tried that may provide um, benefit and hold off a surgical option, that would be my recommendation. If I felt like that patients are that their quality of life is rapidly declining due to these symptoms, and they've had a fair number of medication changes and adjustments and tried different things. I think it's certainly reasonable to start having that discussion and building the expectation as to what this can do for their quality of life.
And is this something that you do yourself, this kind of surgery, or do you recommend people for
Yeah,
this?
no. So I don't do the surgery specifically. I refer them to our neurosurgery colleagues, specifically a functional neurosurgeon who does the implantation. We do the preoperative workup for deep brain stimulation, and then the patient returns to us for the postoperative management.
And what are the tests or the criteria that someone might go through for you to determine that? Are there any specific things like with a cardiac episode, they have like the treadmill test and they have all those kind of things. Or is there anything like that for deep brain stimulation?
Yes, there's two things that are important to do as a workup. One is what you call on-off test. So we evaluate patients, we schedule them to come in in the morning after holding their medications overnight, their Parkinson's medication overnight. We want to assess what they look like without their Parkinson's medication. And then during that same visit, we give them their Parkinson medication. We want to see what that transition to their best motor state looks like. And we do some rating scales to quantify that improvement. And the reason we do that is because we tell patients that deep brain stimulation will do what levodopa does for you when it's working really, really well. But deep brain stimulation will do it for a longer sustained period of time. And the large clinical trials that were done on deep brain stimulation showed that it improved those off periods, those periods where the levodopa wasn't working as well by on average 5 hours per day, which is a significant amount of time. The second thing that I tell patients that who are exploring deep brain stimulation is that we have to get neuropsychological evaluation. So we get a full, complete cognitive assessment of an individual. Because we just want to make sure that we're not missing any sort of cognitive impairments or any mood disorders that we need to address before undergoing a procedure like this.
Wonderful. And how did anyone come up with the idea of deep brain stimulation in the first place? Were they thinking, oh my goodness, the pacemaker works this way, maybe we could do something similar in the brain? Or how did that happen?
Well, that's a great question. Back in the 30s and 40s, the neurosurgeons were doing brain procedures to treat children who had these extra movements with related to cerebral palsy, related to this, and also dystonia. But the way they were treating them is that they would make the same burr hole, they would sort of thread a catheter in and burn a lesion in that area, in the nucleus. So they would sort of lesion the same region that we're actually putting the electrode in for stimulation. They would actually burn that, put a lesion there, and disrupt the network in order to alleviate those motor symptoms. So around the 60s and 70s, they started to notice that before, when you heat the electrode up, there was transient improvement. Because you're conducting some stimulation, there was some transient improvement. So it had some starting to research, could you deliver stimulation into this area without having to lesion? And, the first deep brain stimulator that was implanted was done in France by Dr. Benabit. And he showed that you can effectively deliver stimulation into the same region that you're lesioning. And so that happened in the 80s. So that was sort of the evolution. We went from using a machete on the brain to using stimulation to solve these problems, to try to solve and improve these sort of movement issues. People should keep in mind that with stimulation, we're not destroying neurons. We're not, killing off any sort of underlying neuronal neurons, or what we're doing is that we're modulating networks in the brain, specifically motor networks, movement networks that have become abnormal because of the loss of dopamine due to the disease. And so that's really what deep brain stimulation, that's where the mechanism really is of this therapy.
So let's use our fingers to describe that. So are you saying, in essence, that because the lack of dopamine, right, and the cells, it's the neurotransmitters, right? It's the ability to connect.
Yeah.
So are you saying that what happens is that there's a electrode that helps that stimulation so that things can connect?
Yeah, no,
in the brain?
Yeah.
Is it in essence a neurotransmitter, or is it helping just the whole activity of the network to engage?
So the way I like to think about this is that you're going from a gas-powered engine to an electrical vehicle, to an electrical, right? So the dopamine, when you have dopamine there, the neurons, yes, dopamine, as you accurately said, it's a neurotransmitter. It helps the cells to communicate. Now, the way the cells communicate, also there's a vibration, there's a frequency in which they're communicating with. And when they lose that dopamine, what appears to happen is that there's abnormal vibrations, or what you call oscillations. So these networks start to oscillate at different frequencies due to the loss of their neurotransmitter. And so while on the medication front, we're trying to replace the neurotransmitter dopamine, we're trying to augment whatever dopamine is there by using other classes of Parkinson's medication to sort of, support it, augment it, work in synergy with it. There's these neuronal networks are firing at different rates now, and they're oscillating at different rates. And we know that with deep brain stimulation, that in Parkinson's, you could actually, and there's been a lot of great physiology work now, which has identified certain abnormal neuronal oscillations associated with the motor symptoms of Parkinson's. And when with stimulation, we see that those abnormal oscillations sort of correct, and they sort of are dampened. And so the brain is so fascinating that it not only has the transmitters, but it also has this whole large network of oscillatory behavior. And without the dopamine there, some of the oscillatory behaviors that are meant to slow our movement down sort of take over. And what deep brain, and the evidence now suggests, well, one of the mechanisms, it's not the only mechanism, one of the mechanisms is that it may be helping to dampen those firing patterns, those oscillations that are associated with excessive slowness and rigidity that patients suffer.
Wow. So in essence, is that what levodopa cinematic, is the name for it? Is that what that's doing? I know it has challenges getting past the blood-brain barrier, right? So that's why there has to be sort of more and more of it.
Mm-hmm.
So in essence, but it is trying to do the same thing, which is prevent that oscillation.
That's that's a wonderful follow-up question, because that's exactly what happens. So if you look at those oscillations again, if you look at those abnormal ones, when you give a patient levodopa and they turn on and their levodopa is working, those oscillations also dampen. Exactly right. And so it mirrors what we do with the stimulation. Exactly.
Wow. And so here we are, somebody has Parkinson's.
Yeah.
They've been doing, let's say it's for a number of years, maybe 19 years. They've been changing up medications, they're exercising, they're doing their nutrition, the disease is still progressing.
Yeah.
And they decide that they want to do this because not enough of that cinemat is getting in to control or help manage the oscillations, as we said, in the brain.
Mm-hmm.
So we're saying, okay, maybe we can do deep brain stimulation. Mm-hmm. Now, their choice is going to be an electrode in one or two places in the brain, but the surgeon determines that, or do they?
No, the team. Usually, the way it works at our center, it's a multidisciplinary approach. So after we've done the workup, we would meet with the surgeon, we would meet with the neuropsychologist and our movement disorders group, and sort of review the patient, review what the symptoms are that we think DBS would help with, and then decide on the targets. Which target? Is it a patient that would need just one electrode? Because some patients, their symptoms really are affected unilaterally. Primarily on one side, they're really bothered by the tremor that's on one side more than the other. But most Parkinson's patients on the whole usually require bilateral electrodes. So two electrodes, one on each side of the brain, because it affects both sides of the body. Usually one side's a little bit more affected than the other side. But when it comes to things like wearing off and dyskinesia, that's you need both electrodes, both sides being stimulated to mitigate that.
Makes sense, because there's two sides of the brain, right? So exactly. It makes sense, and the functioning of one side or the other can be regulated. So so that makes a lot of sense. Now, I understand from someone who recently just went through this that they've done the surgery, and there's a couple of days recovery where they're in the hospital. Is that correct? You're not released right away?
Yeah, at our center, and at other places I've worked, usually it's an overnight stay, and you're home the next day after the surgery.
Okay.
Very rare instances, and there might be other medical reasons for a little bit of a prolonged hospitalization, but the vast majority of patients just spend one night in the hospital and they're home the next day, and they come back, in about 2 weeks or so after they've had their electrodes implanted, to have the battery, the pulse generator, implanted, and that's usually a same day procedure, and that does not require an overnight stay.
And tell me again, like the clavicle for everybody.
Yeah.
I don't know if you can see me. We're talking, is it underneath here or above?
It's right underneath the clavicle. It looks like a cardiac.
That's that bone.
Yeah. So if you feel your clavicle here, it'll be right underneath there, maybe a few centimeters under there. It looks like where they were positioned a pacemaker.
Right. And how big is it?
So it's probably the size of I don't want to give away anything, but it's sort of, this is an example of one of them. That's what it's.
Is that like the size of a silver dollar?
Yeah.
A little bit bigger?
A little bit bigger than a silver dollar, exactly. And that's placed right over here, and under the skin again. And the top part here is where the electrode would be connected to the battery.
Wow.
But remember, everything's under the skin. So if you're not wearing a shirt, or you would see the contours of the batteries
Mhm.
under the skin. So usually most of the pulse generators um, are around that size for the most part, and they're
Wow.
all and they're
And
all
has,
MLS compatible.
wow. So I've gotten the surgery, and again, it's a size of a hair, but it doesn't look like a hair, right? It's not like a long thing. It's
Right,
a dot.
right,
Okay.
exactly. It's quite durable and flexible.
And flexible. That's cool.
Yeah,
So
yeah,
I have those in there, probably both sides,
yeah,
and then I have this circular disc here.
yeah.
When when do I know if it works? Does it work right away? Does it take a month? How do I know that this has happened and it's effective?
So most patients will notice a difference on the first day that the stimulator is turned on and programmed in the office. Um, so usually after the procedure and after everything has been implanted in the office, we meet about 10 to 14 days after everything has been implanted, and then uh, we turn the stimulation on. We test the electrode. The electrode itself, at the tip of the electrode, there's four little contacts, and we test those four contact regions at the very tip, which is sitting in that nucleus of the brain. We test for benefit and we test for side effects, because we want to minimize the stim side effects and we want to optimize the stim benefits. And so when we've done that sort of mapping, we then sort of put the patient on their specific parameters on both sides, and then they'll immediately feel benefit. Now, in the coming days and weeks, we always tell patients that it takes about 3 to 6 months to fully optimize deep brain stimulation. And the reason for that is we start to bring the medications now, we start to make adjustments to the medication. And when you're making those
Right.
adjustments, you could have breakthrough symptoms that require adjustment again. Um, and so it's a process. And so patients may be seeing their neurologist every 1 to 2 times a month for the next few months after the surgery, but they're feeling a lot better, and they're usually taking a lot less meds, at that point.
We have a question from our Facebook audience. If the electrode is not on target,
Mhm.
is the repositioning done in the OR immediately, or does it require another surgery?
Oh, that's a great question. If the neurosurgery team that's in the OR when they implant it, if they're not happy with the positioning based on the imaging that's done in the operating room as well as based on the clinical testing that's done, they'll reposition it then and there. And if after a few months we're running into certain stimulation related side effects, or we don't feel that the electrode is in the most optimal position and we can't get the most out of it, then it would require going back to the operating room for repositioning of that electrode.
Now, Parkinson's is a progressive disease. So
Mm-hmm.
let's say that somebody has been using levodopa for years. They decide to augment that with deep brain stimulation. How long does the deep brain stimulation and also continuing with their medication, how long does that work? And then does eventually deep brain stimulation not become as effective?
Well, we don't have any evidence right now that the stimulation stops working. We actually have, in the last year or two, we've had some studies that have published on patients who have had deep brain stimulation for 15 plus years. And it's some of the first evidence we're getting with patients who have DBS over a decade. And what we're seeing, a couple of things that were interesting that we're seeing. One is that their medication levels are less than if they didn't have DBS. Two, their off periods, their motor fluctuations are also less than if they didn't have DBS, and they have less dyskinesias as well. But on the flip side of that, we don't have any evidence um, to suggest that deep brain stimulation slows Parkinson's down, unfortunately, or modifies the
Okay.
disease. However, I'll get back to that point a little bit later on. But what we do see is that because of the progression of the disease, that some of the slowness, um, the wearing off, and other symptoms that we could see with advancing disease, such as some of the walking and balance problems, the speech problems, those things that may arise may not be as amenable to stimulation as the limb slowness, the motor fluctuations, the dyskinesias, the tremor, and the stiffness. But if you have tremor and rigidity, limb rigidity in your arms and legs, um, one thing is clear cut. It's not coming back with deep brain stimulation, even 15 years out. Those numbers are impressive. We hardly see tremor return anywhere close to where it was um, pre DBS.
That's pretty amazing, right?
Yeah, yeah, and this is this is very recent publications that we've seen, and it just shows that it's this level of evidence that will help us better understand how to identify candidates, how to speak to patients about this, because now we now have growing evidence of what this can do long term. And, Caroline, there's been some early evidence that in patients who are implanted very early in the disease process, maybe a few years, 6, 7 years out, that they may not be developing as much of the freezing of gait and gait disturbances as those that did not get it around the same time period. This is very preliminary results. And because of that result, there's a large clinical trial now that has started up um, looking at deep brain stimulation earlier than later in the disease course. So I think it's a fascinating area. We're going to see, and it'll be really interesting to know if in some way having stimulation early delays getting some of these other symptoms, particularly gait issues, down the line.
It's so interesting to me that Parkinson's is so unique and so
Yep.
individual, and especially um, in terms of the rate of progression. So it seems like, is it fair to say that if somebody got deep brain stimulation, that would improve their movement? I know you said stiffness, right, and tremor,
Mhm.
but does it also improve gait enough to say that they would be able to exercise more, and then that might potentially delay the progression?
Oh, yeah, that's a wonderful point, and that does stand to happen with so if a patient if a patient is not fluctuating as much or having dyskinesias as much, then yes, their walking can improve, and their balance can improve because the downturns that they experience during the day aren't happening as much, or the severity of it is much less. So yes, they can participate in a lot of the rehabilitation and exercise therapies. We know that that plays into potentially slowing or having an impact on the underlying disease entity. But I always caution patients when I speak to them that don't do deep brain stimulation to solve your gait problem. Um, it's not the primary reason to do it because we cannot guarantee that it will help. There are patients and there are studies that have shown, and we've seen this as well ourselves in our experience, that patients whose walking gets better when they take levodopa, they also tend to get that similar response to deep brain stimulation. But it's not the reason to do it. The main reason is that you want to have one of those three indications: tremor, really bad wearing off, bothersome dyskinesia. Those are the three indications. Anything else that we get would be bonus. And I just
Gotcha.
want to let viewers out there know that there's a lot of work being done to look at gait and balance using deep brain stimulation to see if there's different approaches that can be developed to help those more medication refractory symptomatology, um, but certainly not the reason to undergo the surgery.
Do you think we're at the beginning of deep brain stimulation in terms of it being used not only for Parkinson's, but potentially stroke patients, other areas? Do you see as you look back,
Yeah.
wow, we're just at the tip, of the iceberg. We're not really even, going just at the beginning, in other words.
Yeah, I want to believe that as well. And the reason I say that is that our understanding of the brain, our understanding of the networks and how they communicate, uh, continues to grow by leaps and bounds. And that has a direct impact on technology like this. There are large trials right now looking at that, at using deep brain stimulation to treat stroke patients. There's a trial that is underway looking at it to treat Alzheimer's disease. Um, so it was approved recently to treat certain types of epilepsy. Um,
Mm.
so its indications, I suspect, will grow more. And the last indication was, I think, back in 2009, if I'm correct, and they had gained indication for OCD, treating patients with really refractory OCD. So you're seeing that the more we learn about the brain and we understand, uh, you know, what the networks, what the areas are that are affected, um, it may lend itself to expanding the use of this technology. But on the flip side to that is that the more we use deep brain stimulation, we are learning about its mechanisms and how and what it's influencing. When they first started using it, we were sort of operating a little bit in the dark as to what were we really doing, what was it influencing. We're still, not completely sure as to all of the aspects of therapy that deep brain stimulation is given, but we surely have a lot more insight than we did, 20, 25 years ago.
The human mind likes to find the easy solution,
Hmm.
right? To take a pill, we know that from diet, right?
Yeah.
If it could only be, this could be the answer, right?
Hmm.
So, in relationship to that, this isn't deep brain stimulation isn't the answer. It's
Hmm.
a tool in the toolbox, right, of managing symptoms with
Yeah.
Parkinson's.
Yeah.
But how do you help in a very candid way? I remember I asked you this question once, which would you recommend deep brain stimulation for your mom? She was, in that had Parkinson's. But how do you manage expectations of someone who's living with Parkinson's who hopes that this, beyond hopes that this is going to help them with these symptoms?
I think that the important thing to um, to tell a patient is to directly let them know what it is that we can expect to get out of deep brain stimulation. That we and that we build the right expectation, that we're not selling a bill of goods that we can't deliver on. And I've seen this happen, um, you know, um, over my career thus far. I've seen it happen a little bit too many times, in which patients were promised something or they heard something very different than what they got. And I think that it's really important, as you said, to meet with patients not just one time, maybe a few times, um, to review the disease state that they're, the disease as it manifests in them. Because as you know, Caroline, that this is a very heterogeneous condition. No two patients are the same, and and that's the approach we have to take with something like deep brain stimulation. We have to make sure that what the person and the individual that's before us, um, that we could really make a difference with it. If we don't feel strongly, based on our testing, based on our evaluation, based on us working with that patient um, and their caregivers, if we feel like we cannot deliver on what we say we can, there is no point in subjecting someone to this, sending them for it. But I do think that this discussion needs to happen, and it may need to happen a few times because it's a lot of information that patients are gathering. Surgery and stimulation, it's a lot to process in one visit. And so that's why, when we do our workups, I'm constantly revisiting the the indications. I'm constantly revisiting what are we going to expect based on today's testing. Now we see, what you look like off your meds, on your meds. This is what DBS will be able to do, and this is what the evidence shows to date. And I think that the more that the patient knows about what to expect, and the family members and their caregivers, they go into that OR with a confidence that really will give them the best chance of getting the most optimal solution. Those patients that go in to this not 100% confident in the decision here is those that I think they don't have the most optimal outcome because they're disappointed. Their expectations, and that's tough. It comes back to the mind. The mind influences our bodies, and there are Parkinson's patients when they're stressed and they're anxious and they're worried, their tremor will come out, or their meds may not work well for a couple of doses. The mind plays into this, and I think that we take this very seriously. And anyone that speaks about DBS to a patient needs to do it with a level of sensitivity, a level of understanding of the family dynamic, the caregiver dynamic, and any other cultural dynamic there before ever, taking them to the operating room. To your question, if it was my mother, and I'll add to that. My grandmother had Parkinson's disease and suffered with motor fluctuation dyskinesias. And when I look back at her, I said, I wish I could have given that treatment to her, because I think I could have made a world of a difference in her quality of life. So I would recommend it to personal family members of mine if I felt that it could improve their quality of life. And if I can't make that argument, and if a patient can't walk out of the office understanding what that argument is or how the quality of life is going to improve, then we didn't do our jobs, and the patient needs to ask follow-up questions and further conversations if they don't feel confident why they're doing this.
Wow, thank you so much. I think this has been a fascinating conversation. And it basically sounds to me like you're advocating for people to advocate for themselves and their caregivers and care partners to advocate to make sure that you really feel like, I know what I'm going to,
Absolutely.
what the outcome is going to be, and I'm confident, and that's what I want before undertaking this surgery.
Absolutely. It's a lot of information, and it may take a few discussions. And the DBS team that's doing this, on our end, personally speaking, that's something that I take very seriously, because I know what it feels like to go into to think about making certain medical decisions with very little information, and I don't want anyone to experience that. You want to give them all the right information, all the most objective information, and that's really one of the key jobs of ours, working with DBS.
Wow, our time has flown by, and I just thank you so much for sharing your lunchtime with us. Is there anything else that you want to leave our audience with? Any last minute thoughts, or do you feel like we've covered it?
I think we've covered a lot here. I thank you again, Caroline, for having me, and I just want to tell viewers out there that don't look at deep brain stimulation as just the last resort. I think that it is a platform that could work in synergy with other treatments, whether it's your medications and whether it's your rehabilitation therapy. Everything's sort of working in synergy, and that's the approach that we take and have found to be extremely beneficial for those considering this.
And if patients wanted to see you or get a consult with you, do they contact Northwell Health, or can we put something in the chat where they could reach you?
Sure. I could provide my my office number.
Okay.
Absolutely. Yes.
Fantastic. Oh, I've just gotten a note that we have that in the chat already.
Okay, great.
I'm not a bit surprised. My team is on it. And I just want to let everybody know, if you'd like to sign up for Living with Parkinson's programs here at the Marlene Meyerson JCC Manhattan, there's a link in the comments below, and there's a short intake form. It's not hard at all to fill in. That's required, but other than that, and signing up, that's all you need to do. Please don't go it alone. There's no need to. We're here for you, and we're just delighted that you're part of our community. Ritesh, thank you so much for
Thank you,
joining me. It's
Caroline.
always a pleasure to spend time with you.
Likewise.
And good luck with your little one. 1 year or
1
a
year.
little older?
Yeah, I've got a 15 months and a 5-year-old. So that's my second non-DBS job.
Both important.
Yeah.
Both important jobs. Well, we'll let you get back to them. Thank you again for joining us.
All.
Remember, you can email Whitney Chapman at wchapman@mmjccm.org for any ideas, comments about the show. If you'd like to come on the show, or if you know somebody that we should interview, please let us know. Join us next week for our next episode of Getting Personal with Parkinson's about influencing factors for PD. Take care, everyone. We'll see you next week. Bye now.